Good morning to you, all of you. And we will be starting today with the Pediatric Pearls to the General Ophthalmologist. It comprehensively discusses about small, very simple things which I think they'd be useful for the General Ophthalmologist. And there are a few take-home messages which would be there. And I think those who are here as the audience, very few, but I think it will be useful.
So I request Dr. Naina Jabin Haider. She heads the Pediatric Ophthalmology Department at RIO Trivandrum to start the session with her topic, Child with Spectacle, Dealing with Myopia.
Good morning to you all once again. I'll be discussing about the child with spectacle. To say, I think these are the little patients who come to our OPD or to the clinic, and the topic I've chosen is myopia. So why is it relevant? It's discussed in all the pediatric rounds that by 2050, 50% of the world population is going to be myopic, and 10% is going to be high myopia. So when you diagnose myopia, it's not enough actually. That is what we can all diagnose myopia. But monitoring progression, that is the mainstay of myopia management. And we can always prevent a little bit, the progression of myopia. That is, prevention is better than cure. Lifestyle modifications, which I think can be implemented in children, and there have been myopia control clinics which have discussed the lifestyle modifications in the form of questionnaires. I think the myopia control clinics are the big thing now. The bus is on myopia control, and just to go through these degrees: mild, moderate, and high. And we know all this, that is 0.5 to 2 diabetes is mild and moderate is 2 to 6. And that is that group which comes to general ophthalmologist, and which are managed by them. And the high myopias are more than 6, and they are the pathological myopia. And there is one condition called as pre-myopia, and the International Myopia Institute have defined pre-myopia as a refractive state of the eye between plus 0.75 and 0.5 diopters in children, where a combination of baseline refraction, age, and other quantifiable risk factors. So they have put risk factors which provide a sufficient likelihood of future development of myopia to merit preventive measures. So pre-myopia is like your pre-diabetes, and myopia is said to be the youngest lifestyle disease. Myopia, they have labeled it as a childhood lifestyle disease. So pre-myopia is one condition, and which has to be treated with the preventive measures. So coming to risk factors, gender-wise, the girls are more prone to myopia progression than boys because they have more of indoor activities and more stuck to books. But these are the studies which show all that. And parental myopia, that is 3 times risk in children with both myopic parents, and a strained visual environment, that is reading and writing continuously and with screens. And we cannot get rid of screens now, but we can control them. Urban is having a more incidence with as a risk factor because the constricted living spaces and higher levels of education, higher levels of aspirations all contribute to myopia. And school type more relevant in India because we do have private schools and the government schools. So children are forced to study, cutting off their PT time. So these are risk factors, and higher individual monthly income. So that is also told to progress myopia. So progression of myopia is multifactorial: genetics, parental myopia, screens, indoor activity, near activity. But a preventive measure is outdoor activity of more than 2 hours per day, so 14 hours per week. That should be recommended and done by parents, and that is prevents myopia progression. So not going into details of the theory of myopia, progression. But the most important concept is a peripheral hyperopic defocus, and that I'll explain. And there are other important ones: the accommodative lag, dopamine and scleral biomechanics, and feedback metroprization. So this is the shape of this is the shape of the eyeball when you come to myopia. So you can see that it is having, when you see the third picture, the myopia is, the shape is like a conical, it's like a cone. Whereas on the left hand side, it's a more normalized spheroid. And so the myopia, as it progresses, there's a conical element, that is, there is a posterior cone, and the cornea is also forward coned. So this is the shape. And to discuss about the peripheral defocus, in an uncorrected myopia, the central rays, as you know, will be focused in front of the retina. And look at the peripheral rays, which are more important. When you have a single vision glasses, that's the traditional lenses which we use, the peripheral rays, that is the more important aspect. Today, Leila Madam was discussing about the peripheral refraction. So these rays will go behind the retina. That is the hyperopic defocus which comes in the progression of myopia, and that stimulates the retina. It sends signals to the retina to increase, bring the elongation of the eyeball. So the hyperopic defocus is a stimulus for further increase in the axial length. Then as I said, growth of the eyeball is not fovea driven. As we all earlier, I think the PG days, we thought it was the fovea which does all the main part of the growth, but it is the peripheral hyperopic defocus which brings about the growth. These are all studies which is done in monkeys, and which is, they have done this study in 2007 by Earl Smith, which demonstrated that there is a peripheral hyperopic defocus which brings about the growth of the eyeball. So myopia progression, what should you do, and what is good for the patient? So when you have this myopia progression, that is why the myopia control clinics have come into the existence. And myopia control clinics, I think it can be set up by the ophthalmologist, but as I said, diagnosis of myopia is not enough. You have to see the progression of myopia, and the AIOS has given these guidelines that must do, good to do, and exploratory test which should be done in a patient with myopia. As you all know, we do the visual acuity, slit lamp, IOP, fundus, and cyclorefraction. Cyclorefraction has to be done with a dilated fundus examination to bring out the myopia. That is, because we'll be following up these patients as usual. We'll be following by 6 months, 1 year with cyclorefraction. And I'll be taking a little more time. And good to do is the axial length, the optical biometry, far enough, which is good. Corneal topography, and fundus photo, tear film assessment. Tear film assessment if you are giving contact lenses. So exploratory also has to be done. That is, peripheral refraction stands top on the list. Pupillary aberrometry, and macular OCT. And treatment-wise, as we know, we give the single vision lenses as a first line, and these are as standby spectacles. So the single vision lenses are given by the ophthalmologist, the general ophthalmologist, as the first line. And as I talked, the progression of myopia, there are options that we'll be discussing, and lifestyle modifications. See, the options are pharmaceutical agents, atropine, and optical defocus lenses. Atropine is 0.01 and 0.05. And defocus lenses, the DIMS, the highly aspheric, that is the halt lenses, the care lenses, and the dot lenses. So defocus lenses, this is the picture which demonstrates the different lenses which have been used for myopia control. I'm not going to get into details, but there is a central 9 millimeter of clear area which focuses the refractive rays onto the retina, and the peripheral lenses will bring about the myopia control. Myopia control designs, what it does do is that the peripheral rays are focused in front of the retina. We have the rays going back in progression, but myopia control lenses will bring the rays in front of the retina, and that will stop the progression. So coming to DIMS and Hall, just going to the spherical equivalent, the difference lenses, the maximum we can give is -10 in a DIMS, and a Hall lenses is -12. And the cylindrical power is also around, you cannot treat more of cylinders. So in myopia, it has to be a truly myopia with little bit astigmatism. And the low dose atropine, coming to that, it is used in the progression of myopia as combination therapy, 0.01% or 0.05%. You have different myopic responders. You have the good responders, the slow responders, and the non-moderate responders. And it should be avoided in children less than 4 years. So because we do give these drops and we have to progress, we have to know the progression of myopia. So mechanism of myopia atropine is not yet clear. That is why the FDA has not approved it yet. And the consent is mandatory because we are using these drops for a long duration, 1 year, 2 year, 3 year, 4 year, 5, and the studies have been going on. So the consent to use these drops is mandatory. So the myopia control clinic have to take care of all this because we are giving this as myopia progression, not as first line treatment. If you have a progression of myopia of 0.05 diopters per year or a 0.15 millimeters of axial length growth per year, you have to document and give these drops, not simply just as a first line. It is as used as a combination therapy. And it's a non-accommodative action which brings about this control of myopia. So it can be used as once daily or twice daily. So things to apply. My last slide is when not to treat. That is progression. That is pathological myopia doesn't have any role for these medications or the optical pure astigmatism. We don't treat them. And hyperopic refraction and no documented progression. So let's avoid, you should not undercorrect a myopia, give the full correction and no prescription without cycloplegic refraction. Thank you.
Thank you so much for that enlightening talk on a subject we all should be aware of. Next, I invite our own Dr. Arya for her session.
The topic is with amblyopia, child with a patch.
So good morning. Thanks to KSOS and Dr. Naina Madam for giving this opportunity. My topic is child with patch tips for amblyopia management. So before going into the management of amblyopia, as we all know, it's a unilateral or bilateral reduction of the visual acuity and it is caused by abnormal binocular interaction during the critical period, which is very important. And while taking history, what all things you should rule out? Always ask for prematurity because history of ROP significantly increases the risk of amblyopia. Whether there is any family history, developmental delay, and ocular history like previous trauma, ptosis, or patching history provides a context. Now, what are the clues which help us to decide whether the child is having amblyopia? Whether there is any fixation preference for the child, whether there is any tilting of head, rubbing of eyes, abnormally increased blink rate, resistance to occlusion of the sound eye, closure of one eye in sunlight, examination of objects close to eye, and presence of amblyogenic factors. So starting from the history, we already identified the risk factors. Check the visual acuity according to the age-matched assessment. Refraction, cycloplegic refraction is mandatory, very, very important. And check for strabismus and rule out any organic pathology. So always do a detailed anterior segment and fundus examination. Now, when to order these investigations? As we all know, standard amblyopia is always a clinical diagnosis, and advanced imaging is reserved for atypical cases or when the treatment fails. OCTs essentially rule out subclinical foveal hypoplasia or any subtle macular edema, and VEP provides objective estimation of visual acuity or pathway integrity. It's useful in non-verbal children or suspected malingering. And neuroimaging MRI only for optic nerve signs, that is pallor, or any neurological deficits are present. So coming to the therapeutic ladder, you check the refraction, spectacle correction. Then you give the occlusion, that is patching the sound eye, which is still the gold standard treatment of amblyopia. Penalization using atropine or Bangerter filters can be given. And finally, the newer binocular therapy. The step 1 is refractive correction. And first you find out the refractive error of the child and give the full spectacle correction and allow a 16 to 18 weeks for visual acuity to stabilize with glasses alone before starting your patching, because most of the amblyopia, according to the Paediatric study, gets corrected with your spectacle correction. And step 2 is the occlusion therapy. And by blocking the visual input to the sound eye or the dominant eye, the brain is forced to process signals from the amblyopic eye. This is a mechanism of occlusion, as we all know, and it overcomes the suppression and stimulates the cortical development. It has a high success rate in compliant patients, and the challenge is always the compliance and social stigma. Now, what are the types of occlusion patches that you can give your child? You can give the adhesive patch. It provides the best occlusion because there will be no peaking and it stays in place. But the problem is that there can be skin irritation or allergy to the patch. You can give cloth over the glasses. It is comfortable, but it is easy to peek around also. And pirate patch, it will be fun to play for smaller children, but it's not recommended due to the high risk of peaking and poor seal. Now, how is the patching dosage guidelines? For moderate amblyopia, that is visual acuity 2040 to 2080, 2 hours per day plus 1 hour of near activity is actually prescribed. The outcome is similar to 6 hours patching. And in severe amblyopia, we prescribe 6 hours per day. And what are the key strategies to maximize the compliance? It is easy when you start occlusion in a smaller child because it is easier to establish the routine in younger children. And you can give some reward systems like sticker charts or special playtime during patching, the engaging activities, and family education is very, very important. Emphasize the neuroplasticity window both to the mother as well as the father. And when do you say that patching is a failure for the child? When there is no visual improvement after 3 to 6 months of compliant patching, no improvement even after at least 3 intervals of full-time occlusion therapy. It's recommended to always taper the patching with part-time occlusion of the normal eye 3 to 4 hours per day or alternately patching both eyes. And when to stop occlusion? When the visual acuity in both eyes becomes equal or the fixation becomes fully alternating or when there is no further improvement despite 3 to 6 months of patching. And recurrence is always a problem in this patching. And when the acuity recurs again, still a slower tapering is advised. You don't, when you see 6/6 vision, you don't say to the parents that, okay, now you can stop the occlusion. You have to continue it for a little more period, taper, and then only stop. Second one is pharmacological penalization, atropine 1%. Atropine drops in the sound eye, paralyzes the accommodation, that is cycloplegia, and blurs the near vision. And it forces the child to switch fixation to the amblyopic eye for near task. Indications moderate amblyopia. Also, when the child is not compliant to the patch, you are not getting a good result with your occlusion alone. And various studies was conducted by Paediatric, and the study result is that weekend atropine provides similar visual acuity improvement to daily atropine for moderate amblyopia. The side effects are light sensitivity, conjunctival irritation. Now, according to the study, for moderate amblyopia, both modalities are equally effective, that is patching for 2 hours or weekend atropine. Both have produced 3 lines improvement. Next is a Bangeter filter. This mechanism is again the same. You can put translucent foils or apply to the spectacle lens of the sound eye. It induces controlled image degradation and reduces the contrast sensitivity of the sound eye, encouraging the amblyopic eye to see. The advantages are that it allows some peripheral fusion, and cosmesis it is less noticeable than a patch, and it's excellent for tapering treatment. Now we are shifting towards binocular therapy, that's a dichoptic therapy rather than patching one eye. And the traditional patching is, as you know, it is monocular and it doesn't directly address the suppression. So goal is that you unmask the amblyopic eye and retrain the brain for binocular fusion. Most of the hospitals in Kerala are also using this Binox. The Binox utilizes modern gaming interfaces to deliver the dichoptic therapy. It's an interactive video games engaging for the children, and it's a real-time adjustment of contrast balance. It monitors compliance remotely. And there is significant visual improvement according to the Lockman visual acuity chart. It is often seen faster than with passive occlusion alone. And the unique benefit is that improvement in stereo acuity depth perception by restoring the binocular cortical cells, which you don't get in a patching. And compliance gamification leads to higher adherence rates compared to the patching. Compliance will be better. Another one is the orthoptic magnocellular stimulator, as we all know, Dr. Sandana Gopal sir, and it has consists of 3 rows of light emitting diodes. And it the first step also helps to improve your hand-eye coordination when the when you point at the light that switches on using a laser pointer. And so diagnose and refract, full cycloplegic refraction, always mandatory. Give the glasses, allow a period of 16 weeks. No improvement, you go to patching, 2 to 6 hours, weekend atropine, and you can reassess after 8 to 12 weeks. Then you go to your advanced therapy, that is a dioptic therapy for binocularity. Then once a child attains a vision, you can taper slowly to prevent the recurrence. So this is in a nutshell what I have already told. And so conclusion, again, occlusion and atropine remains the effective first-line treatments. And treatment should be personalized based on age, severity, and compliance. And early detection, that is less than 7 years, is the strongest predictor of treatment success. And always visualize the fundus to roll out organic pathology, investigate thoroughly, and treat aggressively. Thank you.
Thank you, Arya. You have made amblyopia more simple and easily manageable. But as you know, amblyopia is a very long journey, like your progression of myopia. Next, I would like to welcome Gagi. Gagi is known to most of the people here, but to start with, she's a colleague, very dear colleague of mine in pediatric clinic, and she's passionately involved with her little kids, and I welcome her to the talk with child with diplopia.
Okay, good morning, one and all, and thanking Nana Madam, KSOS, for this opportunity. So, a child with diplopia, how can we tackle the situation? So, basically, how is diplopia different in a child? So, let me go through that. For one, is this the symptom may be difficult to recognize in children. It is sometimes difficult even in adults. They may not complain of double vision. So, if you see frequent squinting or eye covering, eye strain, headaches, difficulty with coordination, frequent falls, definitely unusual head positions, avoidance of certain favorite activities, like sudden avoidance of his favorite video game or television, nausea, dizziness, this may all make us aware of this unpleasant symptom. Now, for us to tackle, we should know the usual causes in children. So children can also have monocular diplopia. It's not exactly diplopia. Usually these conditions cause more than one image. Polyopia, halos, ghost images. But definitely you have to be aware of uncorrected astigmatism, anisometropia, poorly corrected, the spectacles may not be good, keratoconus, etc. But we are more worried about binocular diplopia. And binocular diplopia occurs whenever there is disruption of binocular single vision. So this is where again it differs from an adult. Because in children in less than 7 to 8 years, when the visual system is immature, it immediately, whenever diplopia sets in, it immediately within days to weeks, it goes in for cortical suppression and amblyopia. And so it's just a small window period when the child has some unpleasantness and where we can intervene maybe. And after 8 years, it's almost like adults when they will have diplopia. Now, what are the causes of binocular diplopia? The first cause everybody will think of is definitely the most important, paralytic, trauma, tumor, raised ICT, and even a decompensated congenital palsy. Thankfully, a variety of non-paralytic conditions can also cause diplopia on and off. A decompensation of any phoreas, increasing acute comitant ESO, intermittent EXO, the vertical deviations, Duane's, decompensated Browns. These are all patients with binocular single vision, so they may have diplopia on and off. And consecutive strabismus and of course convergence insufficiency where they complain of diplopia for near. Then all the varieties, the trauma, tumors in children, even vascular lesions in certain predisposed children, neurological conditions of raised intracranial tension, demyelinating diseases, and of course ocular myasthenia should pass through our mind whenever we get something which is not conforming to any particular nerve palsy. Inflammatory conditions can occur like myositis, and very, very rarely we may even think of malingering, though it is very, very rare. Now, Falcon et al. Has done a very good study in 244 pediatric patients, and they found that thankfully 50% were non-paralytic strabismus, causes of diplopia in children. Only 9% were cranial nerve palsies and 9% trauma. And the same study has also found out that an acute onset of diplopia and associated neurological symptoms pointed towards a vision or life-threatening condition. And we can add on to this list papilledema, disc pallor, afferent pupillary defect or other pupillary abnormalities, headache. They are all red flag signs. I mean, diplopia itself is a red flag. These make it more bright. With regards to asking the history, we are asking the parents, and they may sometimes not think some history is relevant. So you can ask leading questions with regard to these symptoms: fever, seizures, weakness of limbs, diurnal varia, especially trauma. They may not think the trauma is important enough to report. So only if you ask a pointed question, they may come out with that. Family history of diseases like neurofibromatosis, vaccination history, pre-existing strabismus, and a family album is definitely worthwhile looking into. It's even called a family album tomogram to look at head tilt and all which was present from early childhood. Now, in evaluation, everything for squint has to be evaluated. The important points could be abnormal head posture, facial asymmetry, all pointing towards an earlier onset. Extraocular movements, ductions, versions, definitely, because the movement defect can be very, very subtle. Again, an uncovered test will bring out phorias because the palsy can be very subtle. It is mainly diplopia which comes first, and later we may see the defect. So don't forget the secondary deviation. Now, children may actually cooperate better than adults. And they are more sharp and intelligent, and we may get a very decent diplopia charting if you spend some time, especially with the older child. Then in vertical deviations, the Park-Bielchowski and the vertical fusional amplitudes, if you suspect it is a congenital fourth nerve. Now, visual acuity, if amblyopia is present, again it points towards a slightly chronic etiology. Fundus for papilledema, disc pallor, torsion of the fovea, pupil definitely, and ptosis. Don't ever forget ptosis, which is a very important finding, and proptosis. Now, coming to investigations, they go usually under the purview of the neurologist or neurosurgeon, to whom we always refer these children. But we should know that the imaging of the brain and the investigations for myasthenia may form the major aspects. Now, as ophthalmologists, how can we manage? So first is the management of all our refractive conditions, the astigmatism and isometropia. Look at the spectacles, any misaligned optical centers. If it's convergence insufficiency, give a start on active orthoptic treatment. And of course, it is a very unpleasant symptom. So patching or the opaque tape on spectacles still is the most important management. But we are dealing with a child, so always remember to patch both eyes alternately. Now, prisms will help us definitely in the interim period when we are waiting for it to subside or to act or to do a definitive procedure. We can divide in between the two eyes. So a ground-in prism is more expensive but with good optical quality. Very small powers, just around 10 prism diopters can be given, and we recommend it only for very stable prescriptions. So Fresnel prisms are more ideal, lightweight, cost-effective, and thin, and we can have in a more wider range of powers. Botulinum toxin, definitely again in the acute comitant, acute paralytic, postoperative, it is given. Different formulations are there. Botox is the usual favorite. So many formulations. The dose depends on the formulation used. 2.5 to 5 units usually. GA, general anesthesia, is required, and it doesn't even require an EMG in the expert hands, can directly inject into the muscle. Surgical management, not ideally, you have to wait till the deviation is stable for more than 6 months at least. And the aim is to give binocular vision in primary gaze or to extend it to the reading position also, and correct abnormal head posture. So multiple stage procedures may be required. It depends on whether it is a complete palsy or whether there is some residual action of the muscle, amount of deviation, whether there is contracture of the antagonist, etc. And a variety of surgical procedures are available according to the condition. So that is all. So we have to make it clear for them, because the window period available in children is very less. Otherwise, it will go in for a permanent suppression and amblyopia. Thank you.
Next speaker is Dr. Minnu Parakal. She has done her DMB from Chaitanya Eye Hospital, Trivandrum, and fellowship from Aravind Coimbatore. Currently, she is working at Chaitanya Eye Hospital, primarily at Trikakara, Kochi, and as a visiting consultant at Tripunithura branch, Kottayam, and Tiruvalla. Welcome, Dr. Minnu. Over to you.
Thank you, ma'am. Thank you for the introduction. So, good morning, all. My topic is watering in children, evaluation and management. Epiphora is the overflow of tears onto the face, often due to an imbalance in the tear film. To understand its cause, we must first review the normal tear flow. Tears are continuously produced by the main lacrimal gland for lubrication and by accessory glands. The drainage system begins at the puncta, flows through the canaliculi into the lacrimal sac, down the nasolacrimal duct, and finally empties into the nasal cavity past the valve of Hasselbalch. Causes of epiphora in children can be classified into two main categories: increased production or decreased drainage. Increased tear production or reflex tearing is essentially the eye's response to irritation. Common culprits include infection, allergy, or presence of a foreign body. Critically, severe photophobia, as seen in congenital glaucoma, also triggers reflex tearing. Decreased drainage is where a true blockage or a pump failure exists. The most frequent cause in the pediatric population is the congenital nasolacrimal duct obstruction, typically resolving spontaneously in the first year of life. Other causes involve problems with the eyelid position or acute obstructions. Etiology vary with the age. Congenital duct obstruction dominates in infants, while acquired or traumatic conditions and the lid malpositions become more relevant in older children. Coming to clinical evaluation. When taking history, note the onset, duration, and laterality. Check if symptoms are intermittent or continuous. Ask about discharge, redness, vision issues, or light sensitivity. Inquire about family eye problems and any prior treatments, trauma, or surgeries. During evaluation, inspect for eyelid position and masses. Check the eyelid for entropion, atropion, and punctal patency. Examine the ocular surface and cornea and assess the nose for trauma or sinus disease. Investigations are tailored by age and findings. Most infants can be managed with clinical tests. Imaging or invasive procedures are reserved for non-resolvers and special cases. The primary test is the fluorescent dye disappearance test. If the dye remains in the eye after 5 minutes, it confirms a drainage issue. Schirmer's test and T-BIRD may be done to rule out dry eyes. Lacrimal syringing and probing are diagnostic and therapeutic, but typically reserved for the operating room for children over 1 year of age. Other tests that may be required are corneal diameter measurement and tonometry if suspecting glaucoma, nasal endoscopy or imaging for trauma, masses, or in case of unresolved cases, conjunctival swab to rule out neonatal conjunctivitis. The differential diagnosis is broad, but every clinician must rule out the must not miss conditions. Congenital glaucoma is the most critical, presenting with a classical triad of tearing, photophobia, and lid spasm. You must also exclude a foreign body or a serious infection like orbitocellulitis. The most common cause by far is CNLDO, but conjunctivitis and other mentioned conditions must be considered, especially with the atypical age, persistent discharge, or systemic findings. Coming to management. For increased protection, the management centers around treating the ocular surface or removing triggers. For infection like conjunctivitis or keratitis, prompt topical antibiotic or antiviral therapy along with the symptomatic care is initiated. Allergic causes respond well to antihistamines, mast cell stabilizers or steroids when indicated. Environmental controls such as minimizing allergen exposure forms an important adjunct. When foreign body is present, it must be removed gently. Residual irritation is treated with the topical lubricants or antibiotic prophylaxis to prevent infection. Paradoxical reflex tearing due to dry eye is managed with lubricating eye drops, and in rare pediatric cases, punctal plugs or adjusting screen exposure as appropriate. Coming to management of decreased drainage. Since the NLDO is the most common cause, we will detail its age-specific management protocol. In most cases of CNLDO in infants, conservative management is preferred. This includes parent-led lacrimal sac massage, known as the Crickler technique, performed several times a day to encourage spontaneous duct opening. Lid hygiene is also advised to prevent secondary infection. Remarkably, over 90% of cases resolved by the child's first birthday. Topical antibiotics are used only for recurrent secondary infection. If epiphora persists past 12 months, or if there are recurrent episodes of dacrocystitis, plasma probing under anesthesia is considered. This is a simple yet highly effective intervention with good outcomes. It can be repeated after 4 to 6 months if the first probing fails. For failed probing or children about 2 to 3 years, silicone tube intubation may be offered. For probing, first the lacrimal punctum is dilated with the punctum dilator, then the lacrimal probe of adequate size is inserted perpendicular to the eyelid through the punctum and then quickly turned to follow the course of the canaliculus parallel to the eyelid margin. Applying traction to the lower eyelid laterally can facilitate easy passage. As the probe advances medially, bone will be felt where the tip encounters the nasal wall. The probe is then turned approximately 90 degrees and is passed downwards into the distal NLD until it passes through the obstruction, giving a popping sensation. Patency is confirmed by irrigating a saline or fluorescent solution through the duct, which should then flow freely into the nasal cavity. For refractory cases, typically after 3 to 4 years of age or in cases with concurrent sinus pathology, a DCR is performed, which is a definitive surgical care. While CNLD dominates, the structured approach is needed for the other diagnosis. Acute dacrocystitis is a serious complication of CNLDO requiring immediate systemic antibiotics, often in a hospital setting, if orbital cellulitis is a concern. Once acute infection is controlled, NLD patency should be addressed. Each anatomical problem requires tailored surgical or medical intervention. Puncture problems are managed with punctoplasty or stenting. Topical steroids may prevent scarring after surgery. Canalicular block can often be resolved with probing or stenting early. Advanced cases require surgical reconstruction like CDCR or injection botox to the lacrimal gland to reduce tear production. When lid position disrupts drainage, surgical correction is required with temporary measures used in some scenarios. Sinonasal disease must be managed fundamentally to restore drainage, sometimes needing combined surgical procedures with ENT colleagues. Any suspicion of associated neoplasm, craniofacial anomaly, or trauma-related obstruction mandates multidisciplinary input and tailored intervention. Urgency is critical in case of suspected congenital glaucoma to prevent irreversible vision loss. The symptomatic approach starts with classification. Always rule out the critical sight-threatening causes. Remember that CNLDO treatment is highly age-dependent, with the crucial cutoff for conservative management being the first year of life. Probing success is time-sensitive. The success rate decreases significantly after 18 to 24 months of age. Treatment for decreased drainage starts conservatively, but escalates to surgical intervention for non-resolving or complicated cases. Timing and selection of procedures are tailored to the child's age, anatomical findings, and comorbidities. Do not forget to look for eyelid malposition and other causes of surface irritation. Thank you.
Thank you, Minu, for the wonderful presentation. I think that doll, you have put it in the video. I think we can always use it in the clinics to demonstrate the cranial massage. Just going in and showing it, I think, gives a better perspective. And thank you once again. Now, I welcome my keynote or our keynote speaker, dear Madam, Dr. Leila Mohan, Madam. She's not, she's known to everybody and she's very dear to the pediatric ophthalmology circle. So just to give you I have to say, so Madam has been the HOD of the Comtrust Eye Hospital, Calicut. She has been the Director Academy of Comtrust. She's a faculty in Alcon Comtrust Phaco training. And she's been training fellows in pediatric, and she's always very close. We always meet her, and she's with this friendly smile. She comes to us, and we always are drawn to that force behind her. And she did her fellowship in the anterior segment microsurgery IOL from Aravind Eye Hospital, Madurai. And she has done Phaco's training in Rajan Eye Care. And she has been under Abhay Vasavada sir, and in also pediatric in LVP with Anil Mandal sir, and just to say, she has already, when I approached her with this topic of a journal, she doesn't mind talking on complex or simple because that's the way she is. She is altogether the pediatric ophthalmologist pan, and welcome, madam, for this keynote address.
I'm overwhelmed. Great introduction. Let me thank Dr. Naina and KSOS for giving me this opportunity. And let me first of all congratulate Dr. Naina for compiling such a important topic, all the important topics that a general ophthalmologist should know. And and I am so happy that visual rehabilitation following congenital cataract surgery is as important or even more important than the cataract surgery per se. So I am happy that she chose this rehabilitation part of cataract to highlight. So surgery for cataract is only the initial step, as we all know, in the long-term process of visual rehabilitation. And it is a lifetime process of assessment of visual acuity, visual axis opacification, change in refractive status, especially for a myopic shift when it can indicate glaucoma, which may warrant in examination under anesthesia. Previously, when I started off, every 3 months we were supposed to do examination under anesthesia because the chance of glaucoma was very high. Now it has come down, and unless we are not able to examine in the OPD, we don't go for examination under anesthesia so often. So amblyopia management, of course, in pediatrics, in every case, it is all the more important in cataract post-surgery. But as Dr. Arya has pointed out, amblyopia is very important during the critical period and our sensitive period of infancy. And the achievement of binocularity and good visual outcome, this is our aim. So why is rehabilitation so very important? So it's more challenging part after surgery, and the infant eye, as we all know, has an exuberant inflammatory response. The fibrinous membrane formation is not, if it is not attended to at the time of formation, it's as good as doing no surgery at all. So babies don't complain that they cannot see. So immediate postoperative follow-up with aggressive steroid treatment and dilatation and pomade and atropine I don't use so much, but if necessary we have to use atropine also, and especially if you suspect an infective pathology like rubella. So age at the time of surgery is also important. Congenital cataract at birth poses special problems. Early surgery is warranted in unilateral by 6 weeks and by 8 to 10 weeks in bilateral, which predisposes the eye to the development of membrane formation and glaucoma. Aphakic glaucoma versus pseudophakic glaucoma. There are some papers saying that pseudophakia protects the eye from glaucoma, but again, the main reason for being aphakia, we leave aphakic, is because of the age factor, microphthalmia, and so many other factors which are the predisposing factors for glaucoma development. So it is not just aphakia that is the reason for development of glaucoma. And the barotrauma during surgery to the immaturely developed trabecular meshwork, as we know, it is very immature at birth, and the vitreous, lens particles, inflammation, all contribute to the development of glaucoma, which is very, after taking all the risk for doing surgery at 6 weeks or 8 weeks, if we are not attending to all these problems, it is of no use. The optic nerve can get damaged. So more refined techniques, of course, with a high cut rate of vitrectomy and meticulous anterior vitrectomy and the use of steroids has definitely reduced the incidence of glaucoma and visual axis opacification. Still, it has to be very closely watched for. So the unilateral cataracts, we know, poses more challenges as the child already has a good eye, and occlusion therapy has to be instituted with refractive correction as soon as possible. So till 1970s, when we were when we were doing PG also, we were told that unilateral cataract is better left alone because amblyopia management is not easy, no IOLs then, and aphakic correction is not so very compliant. if you give a glass. So the risk of surgery versus the risk of dense amblyopia used to be there. But now we know even unilateral cataract, if you are very meticulously following up with amblyopia management, they do give good vision. So in unilateral cases, we have found microphthalmia is a common cause. In our hands, PHPV has been found to be the commonest cause for unilateral congenital cataract. So it has the added risk factors also. So the challenges of amblyopia management, I have stressed upon the point of unilateral cataract little more. Start patching on the very first day. Without FAK correction like contact lens, specs or IOL, patching and surgery becomes useless. Large periods of aphakia produces dense amblyopia. Child may sleep off during patching. So all these things you have to meticulously ask the parent also how they are tolerating. So to highlight a feedback from my patient, the IOL surgery was done at 1 month elsewhere. During a time when IOL was not advised desirable in a child at 1 month. And I was wondering why this fellow put an IOL in this child. But he came with a dense membrane, of course, but membranectomy was done and aggressive patching, and the child is older now. He has vision of 612. So early correction of aphakia definitely proves good if you very closely follow them. So, as we all know, I think mostly a pediatric forum, it's not a general ophthalmology. Still, infant aphakia treatment study, we know 57 children who had an IOL implantation even at 6 weeks. I had the opportunity to see Dr. Edward Wilson, who was the chairman of the steering committee of IATS, infant aphakia treatment study, who was implanting as soon as the child was seen. 6 weeks, small baby, he used to implant the IOL. But the outcome was later published. I'll come to it. And the long-term visual outcome, they said it is equal in contact lens managed and the IOL managed one. Contact lens, in this study, they had to provide about 9 to 11 contact lenses for the child. They used to give it free for the child because it used to get lost. So in a year, which is not possible in our scenario. Oh my God, am I? So contact lens follow-up is not so very compliant in our situation and not very feasible. So primary implant is better according to our LBPI Ramesh Ketanaya study. They have come out with the parameters to implant an IOL in children with no anterior segment distances, no PHBV, corneal diameter better than 10 millimeter, and axial length more than 17.5 millimeter. It is better to implant an IOL even in unilateral cases. These criteria have to be met. But again, we know the unpredictability at this age. We know axial length increases from 16 to 22, mean K value from 52 to 43, and lens power from 34 to 18. And immetropization involves all these factors, lens, cornea, and axial length. And I would like to highlight a child was operated at 3 months and an IOL instead of 42 diopter, I implanted 30 diopter was the maximum I could get from KSOS. So I implanted 30, and there was a residual 15 diopter 15 diopter of hypermetropia, which I was, oh my God, 15 is as good as FAK, isn't it? Hypermetropia. So I used to see the child every month. The hypermetropia used to reduce by 2 diopters, because that is the growth rate at this age. So by the time he was 8 months, it was plus. But then I tried to convince them to correct it with contact lens, but it's not very easy. They are already IOL is there. Then why? So hypermetropia, high hypermetropia is also amblyogenic. So you have to look at that also. So these are the reasons why I am stressing unilateral aphakia a little more. RGP lenses may be more cost effective in our situation. Many children tolerate contact lens during the first year, but it is good enough. If the mother says after that the child is not tolerating, even that is good enough to have contact lenses, at least for some time. So they can be taken up for surgery early. So amblyopia therapy is not easy in these cases because they have a good eye. So patching the better eye to be instituted at discharge at least for 1 hour. that gives you and 1 to 2 hours in 3 by 3 months, 3 hours. This is the schedule we follow, and 4 to 6 hours after 6 months can be done. And older children, 2 to 6 hours, depending upon the severity of amblyopia. Sometimes, so we know bilateral FA do well with bilateral correction of FAK correction with glasses. They are not a problem. So follow-up is most challenging. This macula to be seen undilated, if you can see well, you know the visual axis is very clear. IOP to be followed up, especially if you suspect myopic shift is there, and if you suspect a glaucoma, you have to go for UV. And until 3 to 4 years, the myopic shift can occur. And retinoscopy should be done in every visit. Sometimes my optometrist used to tell me, Madam, last week I did retinoscopy. But retinoscopy gives you an idea of the medium. How clear is the retinal refraction? If they say, okay, even if there is slight opacity, then you know you have to dilate and see whether there is any Elschnick's pearls or something developing. So media for a retina myopic shift, all these things are important. And residual hypermetropia, as we know, is amblyogenic. So bifocals, initially you give monofocals, then you switch to bifocals, and the frames, especially at birth, if you give FAK correction, it touches the lid, the eyelashes. When I take the child for second surgery, sometimes the eyelashes are so large, I snip them for the convenience of wearing FAK correction. So this is a situation where the child was a child, newborn microphthalmic, had cataract surgery at 6 weeks, was being followed up. Large myopic shift was there from 22 to 16 diopter, and EUA showed an IOP, axial length also increased, and IOP was high. And he was started on an AGM, and he just disappeared and came back with a very large. Parents thought that the eye is becoming normal size from the microphthalmia. It was becoming normal size, and we had to do a Ahmed valve. Still, the child's visual outcome was very poor. So this I have already discussed. Sometimes glaucoma is more in microphthalmia, rubella, cataract, and other ocular anterior segment dysgenesis may be associated. So visual axis opacification is the most single most important complication which reduces visual acuity, and there are different methods to prevent. Optic capture is one. Anterior vitrectomy, of course, we do in all these children up to at least 6 years. And there are methods by which we are still trying to prevent this visual axis opacification. Otherwise, you will have to do a membranectomy. In these cases, either pars plana, or these kids came with dense optic capture at the pupil with a dense membrane. It's as good as doing no surgery. So we may have to sometimes cut it from a pars plana approach, and with a limbal approach, we may have to do a membranectomy as soon as possible, and then give refractive correction. So secondary IOL can be considered by 3 to 4 years in bilateral, but can be taken up earlier in unilateral, or children with visual disability, other disabilities, and not wearing glasses. So often it is not possible to do an implantation in the back, so we do capture it behind the fused leaflets of the capsular leaflets. So avoid long periods of uncorrected vision in children. So that is the main aim. And iris claw lens I do sometimes in microphthalmic eyes, where the definitely not less than 10 millimeter corneal diameter. But if you think it is not large enough for our, we don't put an IOL in the sulcus. So sometimes this is a better choice if the capsular support is not there, of course. And ocular alignment and binocularity. Quite often one eye has less vision, so they develop strabismus also. Then that has to be attended. Loose sutures we don't leave for more than 3 weeks. If it is loose, it can produce an infiltrate like this. This child had a tube also there. So any loose suture has to be removed to prevent corneal opacity and infiltration and infection also. So very rarely retinal detachment. If there is a hyperopic shift of the refraction, then you have to suspect, because usually it goes for myopic shift. If there is hyperopic shift, then you definitely look for any detachment, shallow detachment may be there. So do a B scan also. So management of low vision is also important because some children come with cataract and also some cortical vision impairment as well. So in these cases, we have to follow them up with so this is Edward Wilson, with whom I had the opportunity to do an observership. Even he says, even in the US, they are not compliant for patching and they don't turn up at the right time. So this has to be stressed. Each time they come, you have to do a counseling to stress upon glasses, patching, come for follow-up, keep the regular appointment. There is a problem, I say, Malabar syndrome, where they disappear to Gulf and come back after 2 years with dense amblyopia or visual axis of pacification or glaucoma. So these are some of the counseling is very, very, very important. So thank you so much for giving me this opportunity. Thank you.
So, as you have heard from Madam, she's very passionate about congenital cataracts and the management, and she was very thrilled to take up this topic of visual. So, Madam, I think you have stressed on amblyopia management and how initially itself you start on patching. That is, if the child is less than 3 months, you do give immediate patch, and I think the usually.
Try to give, if there is no air bubble and I can have a very good retinoscopy, I tell them you will have to change these glasses maybe after 1 month, but I'm going to give you glasses now. Even if there is a large hypermetropia and an astigmatism, which I know is going to change because when the sutures absorb, definitely it's going to change. So even then, I give the glasses. If astigmatism is not that much, I don't bother about that astigmatism. I just give the hypermetropic correction. And definitely they'll be seen in a week, definitely. Sometimes earlier if I want. This is immediately after surgery, I'm saying. But I do give glasses the very next day if possible. And then patching. But if there is an air bubble, I'm not sure they say access, I would not see all these things, then I ask them to patch from day one and bring them back after 1 week. Naturally, no air bubble will be there. I put an air bubble sometimes after suturing. I don't try to take out all the air. So quite often we are able to give glasses the next day. I start from the and it is not a standard practice to give systemic steroids, but I give a small shot of steroids, which gives that should for the past so many years I don't find so much of the reaction as we saw in the skin. That fibrinous reaction is not there nowadays after starting. It's not a standard practice. If at all we can start hourly steroids will do, but I do give.
As post-op rates, we will do a dilated retinoscopy on
Usually, dilate and after if it is not, if I cannot see the red reflex, I definitely look for the red reflex. I think this is, I'm audible. Audible enough. So, if the red reflex I cannot make out very easily, or if the optometrist tells, or not all, sometimes the optometrist tells me I could not very clearly see, madam. I definitely dilate and see if there is any posterior segment reaction or anything. And if there is an additional need for steroid or but definitely the immediate post-op period is the most important, and that is the time we can encourage. That time they are ready to patch. And because they are the mother, baby is with the mother all the time, they can attend to most of the time. So that is the time I encourage patching, definitely from day one.
how many hours of patching?
But
How many hours of patching?
no, usually what I'm talking about is the congenital cataract which present at birth. We operate by before 2 to 3 months. By 8 weeks, we do the surgery. Definitely by 6 weeks in unilateral cases, 1 hour a day from day one. Then slowly we increase. Rating. No, even earlier. Now, if even before 6 months, actually, yeah, I didn't come to that. IATS brought out after at the end of 5 years, they produced the data, and they had to do lot of cases with additional surgeries for membrane formation. If they put an IOL, implanted an IOL primarily before 6 months, according to the IATS study. So, Dr. Edward Wilson, actually, WSBO's meeting, that is the first announcement of this outcome of IATS was made at Jaipur, WSBO's pediatric conference. So then he said below 6 months, it's better not. But then LB Prasad, they brought out it's not possible always to do a contact lens correction in our scenario, and if aphakia is maintained for some time, amblyopia will come. So it's better to put an IOL if these criteria. I do, but you have to closely watch.
I think we should stop because I think
Yeah.
the next speakers are coming in. Thank you, madam, once again. Okay. We have questions.